Good morning, everyone, and welcome back to Glaucoma for 60 minutes, and we call it G60. And we started this to get you some of the best brains that have been working in glaucoma for many, many years and that have contributed significantly to the literature and to the science and understanding of glaucoma. And today, our special guest is Professor Tin Aung. And I'd like you to introduce you to Dr. Surinder Pandav. Dr. Surinder Pandav is a very prominent glaucoma specialist and professor and head of the Department of Glaucoma. And he's my colleague from PGI Chandigarh on this G60 webinars. And I would now invite Dr. Surinder Pandav to introduce Professor Tin Aung. Surinder?
Can you hear me? Yeah, can you hear me now? Yeah, great. Thank you, Vinay, for starting off this program. And we are very pleased and very honored to have a very eminent glaucoma specialist in this region, Tin Aung. Professor Aung, welcome to this program, and we are very grateful to you that you agreed to address the audience today morning, sparing a very busy time that you have. We know. For the audience, Tin Aung is very well known actually, and he doesn't really need an introduction among our peers, but still I think I would give a little brief introduction. Professor Aung is a clinician scientist in ophthalmology, and currently he is executive director of the Singapore Eye Institute. He's a senior glaucoma consultant and in the glaucoma department and a deputy medical director of research at Singapore National Eye Center. And both these institutions are actually very well known, and they have made a great mark in recent years. He is also a full tenured professor with the Department of Ophthalmology of Yung Lin School of Medicine, National University of Singapore. And in 2018, he was conferred the Kuan Yin Thom Hood Cho Temple Professorship of Ophthalmology at Duke NUS Medical School, Singapore. Professor Aung Tim is currently, he's very widely well published actually, and he has more than 600 publications, which include some of the most prestigious journals like Nature, Genetics, JAMA, Lancet, and you name any top-notch journal, and he has publications there. So he is a very well published and very well-read author and a scientist and a clinician, and he's delivered more than 100 invited lectures in many national and international conferences. He is on the editorial board of a number of journals, including Ophthalmology, Progresses in Retina and Eye Research, Journal of Glaucoma, and Graphes Archives of Clinical and Experimental Ophthalmology. He's a regular reviewer for many number of journals, and we actually always look forward to hear his from his research, because he has a very wide experience, especially in the field of angle closure disease now, which is very close to, I think, to his heart. And apart from genetics, he has done a lot of work in the angle closure disease. And I think today we are very fortunate to have him with us talking about the angle closure disease, because that's also a entity that we often face. So I welcome you again, Professor Tin Aung, and we are honored to have you with us. And with this brief introduction, I hand over the mic to you. Thank you.
Thank you so much, Dr. Pandav and Dr. Nangia, for the invitation. And I'm very pleased to speak today on a Sunday afternoon in Singapore on the management of asymptomatic angle closure suspects, lessons from recent trials. I have no disclosures. So I come from Singapore, and as you know, it's a small country, about 685 square kilometers with more than 5 million people. And these are some pictures of Singapore for those who have not been. It's a modern city just above the equator. So we have a hot tropical weather all year round. In fact, there's a big thunderstorm right outside my window at the moment. And for the last few months, as you know, we've been having COVID, and there were 2 months when we had almost empty streets. This was some pictures of Singapore where you wouldn't recognize that there's hardly anybody out on the streets. Thankfully, now the situation is better, but we still have some limitations of gathering of more than 5 people. And this is a picture of our airport. It's now like deserted. and used to be one of the busiest airports in the world. Now we have probably like maybe 10 to 20 flights a day only. And just a few words about my hospital. This is Singapore National Eye Centre. It's the main eye hospital in Singapore. We have about 65 consultant ophthalmologists, and we do about 15,000 surgeries and we see about 350,000 patients a year. And I'm also the head of the Singapore Eye Research Institute. It's the national research for ophthalmology in Singapore, and we have more than 200 staff in SERI. We have about 40 PIs and about 145 PhD scientists and 25 MD PhDs. And here I have a research program working on glaucoma as well as molecular genetics of glaucoma. So my talk today is on angle closure glaucoma. It's an important cause of glaucoma, especially in Asia, and affects more than 20 million people. It's India as well. It's also a significant form of glaucoma. Now, the prevalence of angle closure glaucoma varies in different populations, but approximately it's about 1 to 2% in many Asian populations. But among the people with angle closure, there's a spectrum of people who don't have the disease yet, the early stage of the disease called angle closure suspects. And as many as 5 to 8% of Chinese people have angle closure suspects. Of those people above the age of 40 have angle closure suspects. So if you look at this, looking at the prevalence between angle closure suspects and angle closure glaucoma, it's clear that most of PACS will not progress to angle closure glaucoma. And we know that the progression rates will vary greatly. In the past, we estimated about maybe 30% may progress from angle closure suspects to primary angle closure, and another 10 to 30% will progress from primary angle closure to primary angle closure glaucoma over a period of time. And this was based on very limited studies, and most of them were small populations, and it was very difficult to get these estimates of progression rates. So let me share an example of a patient, a 59-year-old lady who is asymptomatic, came for examination. She's hyperopia of +2 diopters. Her vision is 6/6 in both eyes. She has very mild cataracts, and her anterior chamber is shallow, but otherwise she's well. Her intraocular pressure is normal. She has normal disc and visual fields, and gonioscopy shows significant angle closure of at least 3 quadrants, but no SNEC here. And this is a picture of the Visanti anterior segment OCT showing angle closure in both angle images here. So this patient has got angle closure. She's got normal IOP, disc, and visual fields with no SNEC here and minimal cataract. So a diagnosis, this is a patient with asymptomatic narrow angles of PACS. So how would you manage her in your clinic? So these are some options. One option is a laser in both eyes, a laser Pi in both eyes, long-term pilocarpine, bilateral phacoemulsification, or observation. Now, if you ask many ophthalmologists, probably most people will give the option of either laser in both eyes or observation. And this is because she has no cataract, she's got 6/6 vision. Probably we won't be doing a bilateral phaco in her. Now, of course, if you send her off and tell her that you can observe her, we worry about being sued because she may come back with an acute angle closure attack, or she may come back a year later with chronic angle closure glaucoma, and this could progress quite quickly as well. So this is what we worry about when we have a patient with angle closure suspects and we send them off without doing anything. We worry about them coming back with significant morbidity. Of course, we can do a prophylactic laser PI, and we know the effect of PI is to treat pupil block. And you can see in this example here where the laser PI will reduce pupil block, flatten the iris, and open up the angle. So prophylactic laser PI can be done for PACS. It can be used to prevent acute attack as well as progression to chronic angle closure glaucoma. But remember, we also have some adverse outcomes of laser PI, such as visual symptoms, corneal endothelial damage, cataract, inflammation, and others. So there are also, it is not completely innocuous procedure. So this is the background for our studies. We wanted to know how should we counsel our patients with laser regarding laser iridotomy, and what are the risks versus benefit of doing a laser PI for PSCS? What is the risk for progression versus observation? And who are the ones who are at risk of progression? Which of the PSCS are at risk of progression? Remember, if you have 5 to 8% of Chinese people over the age of 50 have narrow angles, we're talking about 100 million people or 80 million people in China. And so the economic burden of treating a lot of people with angle closure suspects can be high. Another question we wanted to know is, what is the basis or what is the data to recommend screening for angle closure and offering a laser PI? Should we offer screening followed by a laser PI? And these are some data which we thought were missing at the start of the studies. And so we planned a study called the Zap Trial, and the Zap stands for Songshan Angle Closure Prevention Trial. So it's a very catchy name, ZAP. And this was published last year in The Lancet, and it was a trial of laser iridotomy for the prevention of angle closure, a single center randomized control trial. And as I said earlier, the premise of the trial was to answer the question of how we should manage asymptomatic narrow angles or asymptomatic PSCS. This was a randomized control trial, and intra-person randomization was done. Basically, we recruited people with bilateral narrow angles, and they were randomized to one eye laser PI and the other eye no treatment. So this was an intra-patient randomization, and they were followed up for 6 years. We also did a parallel trial in Singapore called the Analyst Trial, which I'll mention to you in a while. And in China, we wanted to recruit 900 patients and follow them up for 6 years. And the Singapore study was slightly smaller. And we saw them almost at a yearly basis. And the primary outcome measure was the incidence of primary angle closure. So not angle closure glaucoma, but primary angle closure. And this was defined as IOP more than 24 on 2 separate occasions, or the development of 1 clock hour of PS in any quadrant, or you could get an acute episode of angle closure. And we also looked at secondary outcome measures. Of course, if you develop angle closure glaucoma, this is also an outcome measure. So in the Zap trial, the mean age of participants was 59 years, and 80% were female. And most of the iridotomies were placed superiorly, and some were placed nasally or temporally, depending on the location of the crypts in the iris. And we had similar follow-up in both the PI'd eye and the non-PI'd eye. And about 75% of patients in both groups completed the study. And 24 control eyes also received a laser iridotomy for various reasons. So this is the main outcome of the study. In the Zap trial, of the 6 years follow-up, we found that 19 of the laser-treated eyes reached the endpoint compared to 36 of the control eyes. So the so-called cumulative incidence was 4.19 per 1,000 eye years in the treated eyes and 7.97 per 1,000 eye years in the control eyes. And this was significant after you did the after accounting for inter-eye correlation. And the primary outcome occurred in some patients, in 10 patients in both eyes. So in raw numbers, you could see that in the LPI group, 2% of eyes progressed, and for the no treatment group, 4% progressed. So almost double the risk. And the risk factors for progression were eyes with narrower angle at baseline, but this was the only risk factor we found. But baseline intraocular pressure and dark lumen provocative tests were not associated with reaching endpoint. So the Zap trial was a very surprising result because we found such a low rate of progression of development of angle closure, primary angle closure in PSCS people. And this was very surprising. We thought it would be higher. As I said earlier, the previous estimates was about maybe 30%. And of course, the eyes that underwent laser iridotomy had almost 50% reduction in risk compared to the untreated eye. So the hazard ratio was about half. And the study found that the laser iridotomy itself was safe with low long-term adverse events. Now remember, the majority of adverse events was primary angle closure and not angle closure glaucoma or anything significant. It was mostly people who developed synechia and some people developed high intraocular pressure. There were very few people who had acute attacks in either group. And primary ankle closure itself is not really associated with vision loss. It's like the early stage of the disease. Of course, it's a risk factor for development of primary ankle closure glaucoma. And what we thought is that, this low rate progression suggests that the risk of really future ankle closure glaucoma development is really low, even if you do nothing. And of course, blindness is even lower than that. And so, the fact that it's so rare suggests that observation could be an option in patients with asymptomatic narrow angles. And you don't need to do a PI for everybody. Of course, acute ankle closure can result in rare cases, and especially if you have pupil dilation. So this is something which we need to be aware of. And on a programmatic or population level, definitely we do not recommend doing prophylactic laser iridotomy on a large scale, on a population-based screening, for example, and offering prophylactic laser iridotomy. We don't recommend it. Now remember, this was a Chinese population, and perhaps these are so-called higher risk population, because we know that Chinese people have a higher risk of developing ankle closure glaucoma compared to many other populations. In fact, if you were a Caucasian population, the risk would be, we suspect, would be even much lower. Of course, we don't know about the Indian population, but basing on the overall prevalence of the disease, probably is also lower in Indians compared to Chinese. Also, this population was a slightly younger population. These were people in their late 50s, and remember, these were people with asymptomatic narrow angles. And the reason why we wanted this population was because the older ones, people with ankle closure or narrow angles with cataract, are those who will just undergo cataract surgery. So the question is not addressed to that population. We are trying to address people with asymptomatic narrow angles who do not have cataract or very minimal cataract. Another trial issue of the Zap trial is that these patients were recruited from a community setting. So what they did in China was they went to a particular region and they asked people to come for a voluntary examination in the hospital. And so, they would go to a region and they would ask everybody above the age of 50 to come for this eye check. And from this eye check, they would ask them to take part in the trial if they were found to have asymptomatic narrow angles. So this was so-called a recruitment for the community. So it's more like an active recruitment. Of course, if you recruit from a hospital setting, it could be different. Now, before I move on, I'd like to share with you a spectacular picture of a hotel swimming pool in Singapore on the top of this building here. And this is my daughter when she was about 10 years old, about 8 years ago. And this is a very spectacular swimming pool. Looks like I'm going to throw over the edge of the swimming pool. Now I'll move on to the Singapore trial, and this has not been published yet. It's called the Analyst trial, or the asymptomatic narrow angles laser iridotomy trial. Of course, many of my colleagues make fun of me and say that the trial is actually the anal trial. So we have to have a hyphen there in between. Now this trial was similar to the Zap trial. In fact, we almost started a similar time, but the recruitment took so long in Singapore compared to China. In China, they recruited 900 patients in less than a year, whereas we took 3 years to recruit about 550 patients. So it's a huge difference in recruitment rates. And if you want to do any study in clinical trials, China will show you how to recruit patients really quickly. So we had the same study design, one eye laser iridotomy and the other eye no treatment. But our study was a 5-year follow-up, and our trial sample size was 480 patients. And to cut a long story short, we found a very similar, although slightly higher rates of progression in our study compared to China. So our rate was 9% of PACS progressed in the untreated arm versus 5% in the laser iridotomy arm. So it was slightly higher, but even then it was still overall quite low. And the hazard ratio of the risk was again very similar, or half or double, depending on which way you look at it. It's half the risk if you do the iridotomy and double if you don't do anything. And again, the majority of those who progressed developed PAC, and only 3 out of the 480 developed acute angle closure attack. So it was slightly higher, but still overall low. Now we found slightly higher, more interesting risk factors for progression. Those who had narrow angles at baseline, those with higher baseline IOP, those with a higher post-dilation IOP, because we dilated everybody at baseline, as well as people who were diabetic, had also higher risk of progression. So we had slightly more interesting risk factors. So if you put the two studies together, you can see there that the Zap trial was slightly lower, but again, almost the ratio-wise was similar of double, but we had slightly higher in Singapore, 9% versus 5%. So why the difference between the Zap and analyst trials? I think one of them is because the Zap trial was recruitment, as I said, from the community, whereas in Singapore, we recruited from hospitals. And perhaps, in hospital people, they had more significant disease. Also, the mean angle width was slightly wider in the Zap trial compared to the Singapore trial. And of course, there could be some racial differences. In Singapore, we had a more multi-ethnic population with a mixture of Malays and Indians, although we were still like more than 80% were still Chinese. So have these trials affected management of angle closure suspects? Well, I think, firstly, it has given us very good evidence of the low risk of progression for PSCS, asymptomatic PSCS. And these are people who are in the 50s to early 60s with not significant cataract. And so showing you that if you don't do anything or just observation, it is an option. As I said earlier, most of the endpoints was primary angle closure. And so they did not have, most of them did not have developed glaucoma. And really, it raises the question of whether we are over-treating PSCS if we offer LPI for everybody with PSCS. And certainly, as I said earlier, on a population level, we will not recommend laser PI on the community or population setting. Of course, at the clinical level, it's different because when you see a patient in your practice, you have to discuss the options, which I'll come to in a while. And finally, we have to consider other races and other countries, and this data that may not apply to your country. So how do I manage my patients with PSCS now, today? Based on these trial results now, I will give them good information or good data on observation versus laser, because I can quote them two big studies, one in Singapore and one in China. And I tell them if they don't do anything, the rate of progression could be between 5 to 10%. And if you do the iridotomy, it reduces it by half. But of course, the progression is only to PAC and not necessarily to PACG. And I'll explain the risk of both options. And some patients will be very educated and they will say, yes, they understand. They would not like to do the iridotomy. They will observe and they understand the risk. Other patients will say, oh, I don't want to take a risk and I would rather do the iridotomy. And so I would continue as they wish. So it's a more educated or more rational discussion with the options. Of course, some patients will tell me they don't know what to do, or they say, doc, you decide for me. And then, of course, in that setting, I would be more probably on the towards the side of iridotomy, because some patients do not understand a risk, or they don't understand what you mean by observation, etc. So they don't understand this concept. And so I would be more erring on the side of caution. Now, remember, if you have patients with PSCS who are older, who have cataract or significant cataract, then you don't need to do iridotomy. You just go for the lens extraction or phacoemulsification. So these are what I've discussed earlier, are people with very mild cataract or minimal cataract, and they have good vision. And we know that people with cataract, lens extraction is very effective because when you remove the cataract, you remove the pupil block element as well. And in some people like this, where the cataract or the lens is a huge component, then of course you need to do the lens extraction. You don't need to do an iridotomy. It's not going to work. And in such people, lens extraction must be advised. So it is a different population here. Those who have significant cataract is different. You should remove the cataract. And here's an example of a patient, PSCS, with narrow angles. And after phacoemulsification, you can see how the angle opens up. The anterior chamber deepens after the lens is removed. And of course, the pupil block will also be removed. So PSCS with cataract should undergo cataract extraction, without a doubt. So the question people always ask is, so who should go for the laser iridotomy? Of course, I have to firstly remind everyone that people with PAC or PACG or acute angle closure attack or fellow eyes, yes, they should be considered for laser iridotomy. And I'm not talking about this group here. Today's talk is on PACS here. So for among those with PACS, who should go for laser iridotomy is the question. Well, the first group is, of course, people who have symptoms or perhaps symptomatic PACS, and perhaps they may have intermittent acute attack. So some patients will tell you they get, once in a while they get a headache and eye pain, the vision goes blurry, or they get some halos, and it sounds like intermittent acute attack, and maybe they are broken in between, and they have narrow angles on a gonioscopy. These people, of course, you should recommend a laser iridotomy without a doubt, because they may be getting an acute attack, and laser iridotomy may help you to prevent an acute attack from occurring. The second group of people, of course, are those who need regular pupil dilation. So, for example, those who are diabetics, or maybe they have some retinal or macular problems, and they need regular dilation. Of course, you should consider doing iridotomy for the second group. The third group are people who have poor access or poor follow-up. So people maybe tell you that they come from some very far away place and they may not be able to come for regular follow-up. And in such cases, maybe you should consider offering them an iridotomy. Of course, this is not something which we encounter in Singapore because we have a small country and everybody can come to a hospital within 20 to 30 minutes of wherever they live in Singapore. So this is something we don't consider. The fourth group are a question mark, a family history of angle closure glaucoma. So if you have a family history of angle closure glaucoma, should you offer a laser iridotomy? Well, I would usually recommend it, especially if they have significant angle closure glaucoma in the family, because this could prevent them from getting their genetic risk factor. We know that there are genetic risk factors for angle closure glaucoma, and so if there's a strong family history of angle closure glaucoma, I would also offer them a laser iridotomy. And finally, of course, as I said, population or patient specific. So you may need to make your own judgment based on your findings. Perhaps the angle is extremely narrow and they have lots of pigment in the angles, blotchy pigment, which may suggest that they may have some previous acute attack or some contact, significant contact. You should maybe consider that. People who, as I said earlier, who don't understand risk, who don't understand the concept of observation, and population specific, as I said, we don't know whether this data will apply to your population. And if your population has got very large number of people who have or very high incidence of acute ankle closure attacks, then perhaps you should also consider a laser iridotomy for that population. So, for example, I was discussing with a patient recently from Mongolia, and they have a lot of acute attack in Mongolia. So I recommended laser iridotomy for that patient. So of course, there's some population or patient-specific factors which you may need to consider. So in summary, I've discussed to you today the management of primary ankle closure suspects, particularly the asymptomatic primary ankle closure suspects. And I've presented to you two studies, one from China, the Zap Trial, and one from Singapore, the Analyst Trial. And both studies had similar trial designs. You had laser iridotomy in one eye and observation in the other eye, and followed up for 6 years in the Zap trial and 5 years for the Singapore trial. And what we found overall was a very low risk of progression in both groups. So if you did nothing, the rate of progression was between 4% in the Zap trial to 9-point-something% in the Singapore trial. And if you did a laser iridotomy, the progression rate was by half. So it reduced to 2% in the Zap trial and 4-point-something% in the Singapore trial. So the risk doing a laser iridotomy reduced the risk by half. Now, of course, the progression rates were mostly to primary ankle closure. So there were not very few people developed glaucoma, and very few people developed acute attacks. So the risk of the visual mobility is still quite low based on this trial in terms of the primary endpoint. So this gives you data on the optional observation in patients with PACS. Of course, you have to discuss the risk with the patients, discuss all the pros and cons, and patients understand factors that may be that they may develop ankle closure or etc. And Finally, if you're in doubt, please do the iridotomy. This is some patients that do not understand this concept. And lastly, if the patient is PSCS with cataract, please remove the cataract. You don't have to do the iridotomy. This will also solve the issue on them. I'd like to acknowledge here a list of some of my fellows who worked with me in the past or presently. And our international collaborators, Ming Guang He from China, who led the Zap Trial, David Friedman from the US, and Paul Foster from the UK, who are both involved in both the Singapore and the Zap trials. And our Singapore collaborators, Paul Chu from NUH and Wong Hon Tim from Tata Singh, and my colleagues from SNEC, particularly Shamira Pereira and Steve Sia, who was helped at the beginning of the trial. These are some pictures of some of my glaucoma research team. And I'd like to acknowledge funding, particularly from the National Medical Research Council of Singapore, which funded our Singapore study, the National Research Foundation of Singapore, Duke NUS, SNEC, and SERI, and the Kwan Im Thong Hucho Temple, who gives me a distinguished professorship. Thank you for your attention.
Thank you, Professor Tim. That was a wonderful talk. I think there's a great summary of your research work, and that if you do in PSCS, if you do laser iridotomy, you're reducing the risk of progression by half. But the numbers as such are small, so observation is a good option in these patients. So, are there any questions, Prabhat, from the audience?
Yes, sir. There's a question by Dr. Radhika Sriram about whether you would suggest laser PI in both eyes for PACS.
In what context?
She's not mentioned the context, but she's just asked if you would suggest laser PI in both eyes for PACS.
Yes, well, as I said earlier, there are some situations where you should do consider laser PI. So, for example, people who are symptomatic, people who have need regular dilation, family history, etc. And yes, if they have bilateral PSS, of course, you should consider bilateral PI in both eyes. Yeah, I mean, is that I'm not understand? Is this a question? I'm not really clear.
Yeah, I think she would have got the answer. Dr. Radhika, if you're with us, you can write another question and we'll try to take it up. Then Dr. Komaldeep Bedi has asked, how often should gonioscopy be repeated in the observation arm? So if
Yes.
you're
that's a very good question.
LPI, yes.
Yeah, that's a very good question. And I usually follow them up between 12 to 18 monthly, and I do a gonioscopy. I also do anterior segment imaging, and of course, I'll measure the intraocular pressure and look at the disc, of course. But yeah, I mean, I will do that.
So, Professor, do you look at any specific markers in the anterior segment OCT, such as the angle opening distance, or any of the angle measurements that are available with the anterior segment, or just a general idea based on the appearance of the cornea and the angle, and like a qualitative measurement or a quantitative measurement?
Okay, for our research study, we do quantitative measurements, but for normally we don't do. For normal patients, we don't do. Yeah, but as I said, you also have to, what you're looking for mostly on gonioscopy is the development of synechial closure, peripheral anterior synechial, and that is what I look out for. And if they develop synechial, of course, I will offer them iridotomy. Yeah.
So Tin, I just wanted to ask you, in the small number of patients who actually went on to develop primary angle closure and met the endpoint, was there any other parameter that was different from the large number of patients that didn't reach the endpoint?
Yeah, so we are looking at now the anterior segment imaging parameters, and we found that those who reach the endpoint, they have slightly smaller dimensions than those who didn't reach the endpoint. I mean, in terms of the anterior segment damage, it was more shallow, more crowded, etc. But unfortunately, there's no like a cutoff where we could, because everybody was PSCS, right? So we didn't have a clear cutoff within the PSCS who developed SNEC. So that's an issue. But we did find that those who developed had slightly smaller dimensions.
The second question would be that in this group of PSCS that underwent laser PI, was there any other parameter besides the gonioscopy that was associated with the gonioscopic findings? You know, for example, the lens thickness or the axial length or the thickness of the iris. Was there anything else that sort of, you know, met the gonioscopic sort of characteristics to go with?
We did measure all these parameters, but as I said, because they all had narrow angles, so you know the spectrum or spread of the data was very narrow. Everybody were quite closely. The ACDs were all quite shallow. The angle parameters are all very narrow. So it's difficult to distinguish within this group those who progressed. And yeah, so unfortunately it's difficult. I mean, you need a much larger sample size to detect this, because they're all, compared to if you're comparing angle closure with normal people, it's easy to find such differences. But here everybody was narrow, so it wasn't easy to find such differences. Yeah.
Do we have more questions? Borderline,
yes. From here, Dr. Atul Singh has asked, why should you not do an LPI, or why need you not do an LPI before cataract surgery?
Okay, so I suppose it depends on your situation. If you can do the cataract surgery, there's no need to do the LPI, right? I mean, unless you have a long gap or something, you know, and you're worried. Of course, some people came with acute attack, and if you can't do acute a cataract surgery for like 3 months or something, then yes, you should consider doing an LPI first before you do the lens extraction. But for us, if we can do the LPI within 1 or 2 weeks, I think it's quite reasonable to no need to do the LPI, just do the cataract extraction straight away. I mean, there's a very low risk of you getting an acute attack from the dilation on the table. You know, it's very unlikely. I mean, do you all do that? Do you do LPI and a cataract extraction in your practice?
No, we don't actually. We would if we were going for a cataract extraction, then we think that it's that we wouldn't do the LPI because it's one procedure less for the patient, and the cataract, of course,
exactly
takes care of that.
Yeah. So it's not. I don't think it's necessary. Yeah. Unless you have a very long gap.
Yes. Yes.
Sir, would you like to take up the next question, Dr. Vinay? You know, the rest of the question.
Yeah. Tin, there's another question from Dr. Parul Goel. She says that there's a patient with borderline intraocular pressure, unwilling for laser PI, and which anti-glaucoma medication is recommended for prophylaxis?
So the patient's got angle closure with unwilling to do a PI. I mean,
yes, she's unwilling for the laser PI.
Right. I mean, you know, if the patient is one option, you can give pilocarpine, but we don't normally give pilocarpine. We have very little pilocarpine available, so we offer them just a prostaglandin analog to lower the pressure. Yeah, but that will not treat the main mechanism, of course. Yeah.
Okay. I had another question for you, Tin. You know, when you, if anecdotally or through your documentation, you might recollect about the number of Indians in Singapore that came to you with a definite history of acute angle closure, or that you saw with acute angle closure, not chronic angle closure that is presenting with acute symptoms, but an acute episode of angle closure.
Yeah, yeah. Well, what about it?
Did you see these patients in Indian eyes in Singapore?
No, it's very rare. It's very rare. Yeah, probably if we have for we probably get like 1 or 2 acute attacks a week in Singapore, in my hospital,
Yes.
and we have the main hospital. We probably, out of the whole year, we will probably see about between 50 to 100 a year at the moment. Probably like 1 or 2 maybe Indian. Yeah, it's very rare.
Okay.
Yeah. How about in India?
We have the same feeling. We just get this feeling that acute episode of angle closure is very uncommon, rare, and sometimes I don't know whether it exists. We just feel that the acute symptoms that patients come with are basically long-standing chronic angle closure with elevated intraocular pressure, and therefore giving an appearance of an acute presentation.
Okay. Yeah, it's very interesting why Indians may not get acute attack. Yeah.
Yeah, we do see some of these patients coming with acute attack, but I think the numbers are small, so it's not that it doesn't happen that often. Yeah, that's true.
Oh.
Tin, did you get any acute endpoints in Zap study or in the an analyst study? Was there any patient who had acute rise in pressure?
Yes. So in the Zap trial, we had 3 acutes. We got in the Singapore study, we had 3 acutes, and one of them, the patient, the LPI closed off, and he got acute attack, which is very unfortunate. And the other 2, they got acute attack, and one was got acute attack actually after one of the dilations on the yearly follow-up. So one got acute attack after a dilation in the untreated eye, and one got acute attack after some inflammation. Yeah, it's a uveitis which is unrelated, and then one was acute attack in the lasered eye, in the iridotomy closed off. Yeah, but in the Zap trial, they had very few. There's something like 5 or 6 acute attacks. Yeah.
So I think even though the numbers of people going into acute attack is small, but once that happens, the consequences to vision would be grave. You know, if it is not treated and detected in time. So could that be used as an argument to recommend laser iridotomy a little more often PACS?
Well, yeah. Well, it's going to be like, you're talking about like in the Zap trial about something like 4 out of 1,000, right? Yeah. So it's still, and if you divide it up by the number of years, it's still an extremely low risk. Yeah. So of course there is a risk for sure. Yeah.
So because there is a relatively higher prevalence of patients going in for acute attacks of angle closure in Singapore Chinese eyes, therefore when you see a patient who has occludable angles that you took for inclusion in your studies, do you ever dilate these patients, or do you first recommend would you first recommend a laser PI? Or what's your attitude and approach towards dilatation of these patients, whether you have decided that they should undergo laser PI or you have decided that they may not undergo laser PI?
For the trial, we dilated everybody at baseline, and we 2 years and then 4 years. So we dilated, and we gave everybody one type of Dimox after dilation. But there was 1 or 2 people who had acute attack, as I said earlier, and actually we published this because we screened something like 900,000 people for the trial, and we dilated everybody who was screened, and like 1 or 2 people got acute attack. So it's pretty low risk. Yeah, and we published this as well. Yeah, but of course there is a slight risk of dilation in narrow angles. So as I said earlier, people who have narrow angles who need regular dilation, we should offer them a laser PI.
Yes.
Yeah.
Yes.
But for our trial, we did dilate everybody. Yeah.
Okay. We also get the feeling in India that it is not so unsafe to dilate such patients, and that it is actually rare to trigger angle closure in such patients.
Yeah, we agree. But we give them a Dimox 1 tab before home, and we told them to come back if they get symptoms. Yeah.
Yes.
Yeah.
Yes. Surinder, do you have anything to?
Yeah, I just wanted to ask, I mean, how much do you depend on anterior segment screening for classification of these, but anterior segment imaging for, classifying these patients into, PACS or PAC? Are you using screening for this purpose, or is just a gonioscopy?
No. So gonioscopy is the main method because you will pick up the enclosure, you can pick up the SNEC here, and you can do indentation. But for anterior segment OCT, we do it. It's mostly for to record, to document it, and to document enclosure. Patients will understand it. They see it. They understand it, and also to look at response to treatment, for example. And after iridotomy or after a lens extraction, you can see the effect. But it's not crucial. I mean, it's mainly for documentation purposes and also for research purposes. Yeah. But in some people, you can see, for example, the lens is a huge lens. Yeah. And sometimes it's difficult to tell clinically. The lens vault is very big. The lens vault is the anterior part of the lens, which juts into the anterior chamber. And sometimes it doesn't look that big, but when you look at the Visante, you can see the lens vault is like, I showed you an example, a very extreme one, where it looks like a volcano. And in those people, then sometimes these lens vault are quite big, but the vision may still be quite good. But their vision is still good, but I would recommend for them early cataract extraction because the lens vault is the main reason why they're having this angle closure. And so that in those people, it's quite useful when they have the very big lens vault, when you pick up those big lens vaults. Yeah. And sometimes the vision may still be like 6.9 or even 6.6, but because the lens vault is so big, you have to you should recommend them to take out the cataract because that's the main mechanism. Yeah. In fact, we published this before that lens vault and visual acuity has poor correlation. Yeah. People with a very big lens vault may have good vision still. Yeah. So you don't have to depend on the vision.
As you mentioned, looking for SNEC on gonioscopy is actually a very important part of gonioscopy, and that helps you classify these patients and also assess the risk of angle closure.
Yes.
The imaging perhaps doesn't do well as far as
No.
identify SNEC is concerned.
It's difficult. You cannot identify. It's difficult. Yeah, unless it's very, very gross. Yeah.
So there's another question from Dr. Badri Narayan. Any precautions to be taken when a PSCS eye is taken up for cataract surgery?
Sure. I mean, any patient with angle closure is a bit more difficult to do. The pupil, may not be well dilated. The anterior chamber is shallow. The lens is going to be bulky. It's a bit more difficult to do than others. And I suppose you need to be pretty experienced to do the bulky lenses in a shallow anterior chamber. And of course, there's a higher risk of complications. And often I find that vitreous pressure is pretty high as well in many of these angle closure patients. Yeah. So you have to be more careful in your surgery, but I don't do anything otherwise. I mean, in terms of surgically, I don't do anything. Of course, I don't think most of these people, you don't need to use vision blue. I think it's not like very bad. These are not dense cataracts kind of thing. Most of them are very mild cataracts. Yeah. But I mean, how about for you guys? You do anything different for PSCS with cataract?
I mean, we get a sense that if the patient does not have PAC or PACG, then it's not so difficult to deepen the anterior chamber using viscoelastics while when you're doing cataract surgery. But I think if you have a patient with PACG with shallow anterior chambers of 2.2, 2.3, something like that, then I think those anterior chambers we are not able to deepen properly, even using viscoelastics. Almost as if you can't push back the iris lens diaphragm. And in these patients, I think we have to be extremely cautious. Besides using the 2.2 phaco incision, we've also had to do vitreous taps to deepen the anterior chamber and to bring about additional safety for cataract surgery. So that's been the experience with Indian eyes. Surinder, how about you?
Yeah, I think I agree with you more on the same lines, because most of these patients, they can be dealt with without any additional procedure or any difficulty. There would be a very small number of cases where you are saying that you could have difficulty in deepening the anterior chamber, but by and large, they do very well, like any other cataract surgery. Tin, I just wanted to ask you, do you do any kind of synechial lysis when you're doing cataract surgery in angle closure disease patients?
Yeah. So for people who had a recent acute attack and cataract surgery, at the time of cataract surgery, you can do senicylitis. But we did a trial recently on phaco GSL versus phaco alone for chronic ankylosing glaucoma, and the study found that there was no difference in IOP outcomes between phaco GSL versus phaco. And Tanuj Dada also published a similar trial from Delhi of phaco GSL versus phaco, and he also found no difference in the IOP outcomes in the phaco GSL versus phaco. So both studies suggest that although conceptually breaking the GSL makes sense, it doesn't seem to have any effect. Yeah, so the surgeon is happy because he's doing something to break the synechiae, but both studies showed that there was no additional benefit of the phaco GSL. Okay, and I don't know how to explain this. Perhaps it's because the GSL is already long-standing, and breaking it has got no effect on the function. Yeah, but in our study that we published, there was a subgroup of people who did better if they had a GSL after acute angle closure. So probably they are more recent onset, and so those group they will benefit from the GSL because there's probably of a more recent onset. It was a chronic angle closure glaucoma. We don't know how long they had the GSL, the synechiae is there, so we don't know. Perhaps there's no effect. Yeah, but please read up both studies. One from our group and one from our group was a multi-center study with Vietnam and Hong Kong, and the other study was published by Tanuj Dada, and also he found no difference in the phaco GSL versus phaco. Yeah, which is very disappointing. We were hoping that the phaco GSL would be much more effective than phaco. Yeah.
So there is a question from Professor J.C. Das, and he asks that how often would you use 1% pilocarpine to prevent an acute attack? So if you had a patient of PACS or if you had a patient of PAC, and in any of these patients, would you use pilocarpine to prevent an acute attack?
Yes, I mean, if the patient has had an acute attack in one eye and the other eye has not had treatment, I would use pilocarpine as a prophylaxis. Yeah, but in Singapore, we don't have 1%. We only have 2% pilocarpine. We don't have only pilocarpine. We have is 2%. Yeah, we have no 1%. We have no 4%. Yeah, so yes, in those people who had acute attack in one eye and while we were waiting for the iridotomy in the prophylactic in the other eye, I would use pilocarpine, yeah, as a prophylaxis. But it's usually a short-term prophylaxis.
Dr. Badri Narayan would like to ask if there is any correlation with the axial length of patients with PACS.
What we found is that most people with angle closure have small anterior chambers, but the axial length may not necessarily be extremely small. Of course, you have to the people who have the microphthalmos and those people, nanophthalmos, of course they're different. They are everything small, but for the average angle closure patients, it's mostly the anterior segment which is smaller, and the axial length may not necessarily be that small. Yeah. So in Singapore, at least, we have people who have angle closure with no myopia and in hypermetropia. We don't have that many hyperopia. I think it's different. Like Caucasians, a lot of angle closure are mostly hyperopic. In our population, they're mostly very mild hyperopia, or ametropic, or myopic. Yeah, and we have a very interesting group of people who have high myopia, up to 5 to 6 diopters, but the anterior chamber is very shallow. Okay, and what we suspect is that these people would probably have got hyperopia or ametropia with angle closure, but when they were young, they had all these environmental triggers which caused them to get axial length elongation through vitreous cavity elongation. And we published on this before. So these are people who have small anterior chambers but big vitreous cavity, and overall they have axial myopia of up to 25, 26 millimeters, and they can go up to 6 diopters of myopia, but they have angle closure. And because the anterior chamber is very small and they have shallow anterior chambers, So we suspect that this group had this environmental triggers when they were young, and they got vitreous cavity elongation, but their anterior chamber still has the same predisposition. So the very interesting patients, these patients. So don't assume that all your myopes will be open angle. We have some people who have 2.2 anterior chambers, but their myopia of -5, -6. Yeah, it's a very funny group. Yeah, I don't know whether you have such patients in your practice.
I mean, the only thing that comes to my mind is, children who are born premature. Because of laser treatment, they tend to get myopia. I've not had a chance really to study their anterior segments, but from many years ago, I recollect that some of these patients had very shallow anterior chambers. So maybe that is something that is a separate group, even perhaps different from what you have just mentioned.
Yeah. So I'd like to share a very interesting story. So one of my first patients who I had in this category is a very VIP from Singapore, and he was referred to me, and he had he's a -6 myope, and then the patient was referred because of high intraocular pressures, and I did a gonio, and it was like closed all around, and I looked at his anterior chambers like extremely shallow, like, so I did the measurements. It was like 2.3, but his vitreous cavity was like 20 something, and he had an axial myopia, and so I did the Visante, and it was very close. It's very crowded anterior chamber, but he has very excellent. And then after that, we started doing looking into all our patients, and we found quite a few of these patients, but probably maybe like 50, 60 out of like 1,000. It's not that rare. And then we found more and more people have this phenomenon of shallow anterior chamber with long vitreous cavity. Yeah.
Okay, that's very, very, very interesting. There's a question from Dr. Tejit Singh, and again going back to whether is gonioscopy still the gold standard clinical tool for PACS compared to the anterior segment OCT?
Yes, it is the clinical tool that's easy to do, and it doesn't cost very much money. But of course, the most important point is that you have to be doing it. And I know a lot of my colleagues, they don't do it, or they don't not very confident of their findings. In which case, then I would say that then you do a OCT or imaging, and then at least you pick it up rather than missing it. Yeah, I mean, I have to be pragmatic here. Yeah, but of course, I work in a big hospital, so we have all these facilities. But if you're in your solo practice, then please do the gonioscopy. It's much easier than getting a machine to do it.
Tin, I'd just like to ask you a very hypothetical question. Assuming that for these PACS studies, you had not done gonioscopy, but you had only used the anterior segment OCT, and based on that, you had sort of carried out the study. Would you then have found anything different, or you think that it may not have been that accurate or not been that clinically real life valuable?
The anterior segment OCT tends to diagnose angle closure more than gonioscopy, because I think when you do gonioscopy, you tend to press a little bit on the angle, and also you do need a bit of light. So between the two, I think the anterior segment OCT is a bit more sensitive in picking up angle closure. Yeah, and we published a study a few years ago when we found that people who were diagnosed as anterior segment OCT positive, but gonioscopy, they were thought to be open, and you follow them up for 4 or 5 years, many of them developed angle closure glaucoma. So perhaps it seems like the imaging was more accurate or sensitive in picking up these people who developed incident angle closure glaucoma. Yeah. So in fact, it's the other way around. I think the gonioscopy are missing people.
Okay, we have another question from Dr. Hiruni Vijayasinghe. And how often have you seen APAC in individuals younger than 20 years? And how would you manage an individual like this?
I've never seen APAC in younger than 20 years, but I mean, it could be like a non-ophthalmos or micro-ophthalmos kind of a picture. Yeah.
Yes.
I've seen one in the 20s, with some kind of funny syndromic disease with a very very small anterior chambers, and it had some kind of a retinal abnormalities, and it came in a family. They all had similar kind of findings. Some kind of, I think it's some kind of anterior segment syndromic dysgenesis.
And what was the percentage of hypermetropia in the study group, in your study group?
In the analyst study, about 30% were hyperopic. Most of them were myopic, mild myopia or ametropic.
And you're defining myopia and hypermetropia based on axial length, or you're defining them based simply on refractive error?
Refractive error.
Okay. There's another question from Dr. Shrishti Raj, which you have already answered regarding angle monitoring with gonioscopy or angle OCT. So we will skip that. And then how much rise in IOP is considered significant post dilatation to consider for laser peripheral iridotomy?
It's a good question. I think there's two cutoffs, more than 5, more than 10, and I think, you know, if you have anything more than 5, I would be considering doing it. Yeah.
Okay, that's fine. So this is also a question that you have answered for patients undergoing cataract surgery, whether they can be dilated with tablet Diamox. And then there is a question that's it's a different spin on what we've been talking about. That is the role of lens extraction compared to laser PI if you have a thick lens that is well documented.
Yes, I think if there's a very thick lens, a big bulky lens, especially a big lens vault, I would recommend early lens extraction.
We would agree with that. Actually, we measure the lens thickness in our patients also, and that to some extent also decides how we are going to manage. So that's again for angle quantification. That's something you have answered. And then sorry, go ahead.
I mean, is there any cutoff that you use for a lens thickness, like 4.5 millimeters or, you know, less or more? So what is the guide to say the lens is thick, or do you match it with the axial length?
Yeah, I think it's a good question. There's no cutoff that we use, but I look at the lens vault more than lens thickness. So the lens vault is on the anterior segment OCT. You draw a line from the two scleral spurs, and the lens vault is a part of the lens that's anterior to this line, and this is the one that's more important, I think. Yeah, and we have published this value. I think it's around 400 microns in Singapore, but you know, this is, even if you don't measure it, you can eyeball it and see how much it juts into the anterior chamber. Yeah, but I mean, that's more subjective, of course. Yeah.
Then we have a question from Professor Das, and he asks that most of PACS patients directly progress to chronic bypassing the acute stage. This is something that we discussed, but you can still answer that. That patients don't go through an acute angle closure and they directly land up with chronic angle closure.
Yes, I agree. Yeah, I think in this angle closure spectrum, chronic angle closure is much more common than acute angle closure. So certainly most people would have progressed straight to chronic angle closure and not go into acute. Yeah, so I agree with that comment.
And then we have a question as to what is the gonioscope that you prefer to use?
Yeah, so I like the MagnaView. MagnaView is a nice lens. It is good magnification. I also use the Goldman 2 mirror, and I also use the Sussman as well. So they're all fine.
There's a question from Professor Kashinath Shenoy, and he would like to ask whether you use a combination of argon and neodymium YAG laser, or would you just use a YAG laser alone for laser PI?
In our hospital, our protocol is a combination sequential argon YAG. So we do a Argon Pre-Treatment. Usually we use 50 microns, 0.05 seconds, and we start with a 0.5 watt, and we usually do like 10 to 15 to create a little crater, and then we do switch to a YAG. We don't use much YAG. We use maybe 2 millijoules, one shot or two shots, and to create the hole. Yeah, and this is what standard is what we do usually. So usually about 10 to 15 pre-treatment, and then you create like a crater, and then one shot of our YAG. Yeah, we don't usually just use YAG alone. Of course, you can do YAG alone as well. Yeah, but usually YAG alone you may need a slightly higher power.
How much do you space these two lasers on the same day or in different days? Like,
no, immediately.
Okay.
Immediately, yeah. Once you have the Argon pre-treatment, you like a crater there. The YAG is just one shot. Yeah, it's very quick.
And what is your, how do you use provocative testing like prawn provocative darkroom test? And how does that influence the management of your patients?
We don't use a provocative test in our hospital. Yeah, because I think we've looked at it and we didn't find it very useful. Yeah, and in fact the Zap Trial also published on this. The darkroom provocative was not helpful at all. So I think it depends on your own practice, but we did not find it useful. We don't do the only provocation we use probably is like the dilation, but we don't do provocative tests.
But this is a slightly difficult question because Professor Shinoy asks that after cataract surgery, how many millimeters of mercury will come down, and how deepening of anterior chamber depth how much does the anterior chamber depth deepen after cataract surgery?
So this is for angle closure glaucoma?
Yeah, I guess this is because it's not so relevant for PACS.
Yeah. So if you look at our trial of phaco versus phaco GSL, our phaco group, the IP lowering was something like 4 to 5 millimeters of mercury. So it was very impressive, just phaco alone. It's angle closure glaucoma. And these were people who had PAC or PACG. So they had previously significant, did not PACS. Yeah. So that was why the phaco GSL group, they did well in a way that their IP lowering was like 5 or 6 millimeters. I can't remember, but the phaco alone group was surprisingly so great. Yeah. So that's why there was no significant difference. And people who say that they did phaco GSL and they find wonderful effects, yes, it's probably correct. They did. You do find wonderful effects because your IP lowering could be 5 to 6 millimeters. But if you did a phaco alone, you will also find a similar effect. So that was what was very surprising. Yeah. I mean, in the trial, Tanuj Dada's trial also found very good lowering with just phaco alone.
Yes, Surinder, do you use cataract surgery alone for primary angle closure glaucoma patients with elevated intraocular pressure?
Yeah, I do quite often. In fact, I think we have done many times, even for where the IOP is not very well controlled, but there's a significant cataract. So you remove the cataract first and see what happens to the IOP. And as is being discussed, it does lead to 5 to 8 millimeters of mercury IOP in our I think series. There was a reduction in IOP just by cataract surgery. And in fact, some of our patients, we have published data, I think a couple of years back, some of our patients who were thinking in terms of doing trabeculectomy or a phaco trap for these patients. We just opted for just a cataract surgery, and many of these patients actually didn't need any filtering surgery later on. The pressure was controlled with a few drugs, after phacoemulsification. So they did need some, anti-glaucoma medicines, but I think the IOP was well controlled without any subsequent surgery. So I think it does make a difference if you do cataract surgery, if you give a chance to cataract surgery before considering glaucoma surgery for these patients. So I do take that approach here.
Thank you. And there's an interesting question from Dr. Shrishti Raj that if there's a patient diagnosed with PSCS, but the patient is not willing for follow-up or laser PI, would you then give prophylactic medication to this patient?
What's the point? And the patient not going to come for follow-up.
I mean, that's life in India.
Yeah, but where the patient will get the medicine subsequently? No point.
They have relatively easy access to medicines in their villages. Then they have access to doctors who can treat them for glaucoma.
I don't know. I suppose you can, but I'm not comfortable giving patient medication without even checking anything.
Yes, just scientifically, I think it is a challenge, but you know, socially, these are the patients that we often have to deal with, and it is a big dilemma to have this kind of socio-demographic profile of your patients. So I think that's been a great session. And Tim, do you have any concluding remarks before we sign off?
No, no. I'm. Thank you for inviting me. It's a very stimulating discussion.
Thank you, Surinder. You want to say something?
Yes, thank you. We just want to thank Aung basically to give his time to us, and I know how busy he is, but thank you very much for spending your Sunday afternoon with us. And it was just it was a great session actually. A lot of learning and a lot of queries are still there, and I'm sure everyone is benefited. And thank you very much.
Thank you.
So
I'd like to thank PGI Chandigarh for also collaborating with us, and particularly Dr. Kaushik.
Yes.
Thank you.
Yeah. So we have a collaboration with TIN, and we are doing that Asia TBT study. So I think we'll have results, you know, sometimes, you know, in near future. So we look forward to that. Yeah, absolutely.
Thank you very much.
Thank you very much, everyone, and we'll look forward to having all of you with us next month. Thank you, Tin.
Okay, thank you.